multi-service, CENTCOM, and SOCOM. He presented in the outpatient setting in February 2015. No complaints. He was sent here because of an EKG. We see a lot of patients who are sent here because of what's called abnormal EKG as a diagnosis. Since 1992, he's every time he shows up somewhere, his EKG is performed, and somebody says, "Hey, you got a weird-looking EKG," and so he had an EKG that was repeated at MacDill Air Force Base that showed new T-wave changes, and he was referred to us. He has no symptoms at all whatsoever. And so, Malika, here's one EKG that we have on him that's his oldest EKG that we could find. Would you like to take a stab at this, Malika?
Sure. So the rate is, sorry, I can't read those lines really well.
It's probably about 65 or so, or 60.
And for the rhythm, there is a T wave from every 2 hours complex. And looks like it's a normal axis deviation. And I don't see any ST or depressions. I do see elevation in T waves in V2, V3, V5, V6.
What would you call the T wave? The ST segment elevation, what would you call that in terms of terms?
ST segment elevation?
Yeah, what would you call it? Is that early repolarization? Is it acute injury? Is it Brugada syndrome? Is it something weird?
I would probably call it early repolarization.
That's good. And then there are two kinds of early repolarization. One type actually is associated with sudden death, and the other type is normal, seen in a lot of athletes and seen in normal people. Any characteristics of this type? Is this a bad one or a good one?
I think this is a good one.
Yeah, you're right. You had a 50-50 chance on that one. It is a good one. And the bad one has ST segment depression or horizontality that somewhere begins or is involved in the ST segment elevation, early repo type pattern. And so this is different from that pattern. You can look it up online and see there are two patterns, and this is the common pattern. So this is the good one. So basically, the guys had some exercise tolerance testing that was normal. He had a transthoracic echo, 1992, and there were no abnormalities. And there was some question about something there, pulmonary flow, left to right flow. That's probably artifact. And it was repeated, and it was indeed artifact. It's probably coronary sinus return, looking like an atrial septal defect or PFO, which it wasn't. We have another EKG, which is the most recent, which resulted in his referral to our office. And so, Pooh, would you like to take a stab at this one?
Sure. It's sinus, rates with the normal limits, axis is okay. Obviously, the thing that's jumping out are the T-wave inversions, which are pretty deep, more than 10 millimeter T-wave inversions. So that will go in favor of gamma apical hypertrophy kind of pattern. At least that's a consideration. Ischemia, sure, can mimic it, so you can't rule it out 100%, but there's no really Q waves, although the picture is not very clear, but I don't see Q waves or anything to go along with it. At least from my screen, V2 looks a little bit elevated, but I'm not sure it's my screen or if it's really there. ST segment. Other than that, yeah, the T-wave inversions are what are really jumping out.
Okay, definitely this is a strange-looking EKG that knocks your socks off. And so No question, there's still ST segment elevation somewhat, and then there's these deep T-wave inversions kind of everywhere. So let's see what we found out on this patient next. He shows up in the clinic, and this is what he brings with him. And his history: father had coronary disease, had bypass grafting twice, grandfather passed away in his 50s from MI. Family history is very important, especially in coronary artery disease or sudden cardiac death or weird EKGs. And so there's the family history. Social, doesn't smoke, and he's on a statin drug for elevated cholesterol. So is everybody else. He's on fish oil too, like everybody else. And so physical examination, nothing. And what to do next? He's in our clinic for the first time. Let's see. Malika, what do you think we should do in this guy in our clinic?
So I would go ahead and get an EKG first.
That's a good one. I like that. Here we go. What do you think about this EKG? It's prettier than the other one.
I see T-wave inversions. 1, 2, 3, almost everywhere. And I see ST segment elevation in V1, V2, V4, V5. So this is an anterior and septal MI.
So, and we don't have any Q wave. So this guy has no chest pain. So would you still support that diagnosis?
No, but just by looking at the EKG, he has ST segment elevation in leads V1, V2, and then V4 and V5.
So you think this could be like a STEMI?
Going by just the EKG, it could be, but patient is asymptomatic.
Because we presented an asymptomatic patient like this the other day, and turned out to be a Takotsubo without symptoms, an asymptomatic Takotsubo with lots of EKG changes just like this, ST signal elevation, T-wave inversion, all this stuff, and the lady was a Takotsubo and took her to the cath lab, and he had normal coronaries. That was our last presentation, I think. Yeah, so what do we do now, Malika?
Well, we don't know if that's what this patient has. So I would probably take the patient to a cath lab and see what's going on.
Okay, the Takatsubos as we see are basically usually female. I don't remember a single male Takatsubo in our practice. I've never seen a guy with that. So that sort of excludes that quickly for me. Never having seen that. Doesn't mean it doesn't exist, but I've never seen it.
Okay.
So we did an echo, and there's a little thickening. Could be an athletic heart. The guy works out. And so like mild concentric LVH would give you a thickness of maybe 12.5, 13. And then everybody's got a little non-obstructive left common carotid plaque. We look all the time, and there's a little bit there. And this is non-calcified. So we saw that. And so what are we going to do next, Malika?
Mild concentric LVH.
Yeah, it could be an athletic heart. It's a guy who works out quite a bit. Most of our guys from the base have a little thickness because of working out. And here we go. What to do next? We're going to do a stress test, CCTA, cardiac MRI, Holter monitoring, lipid profile, CRP, medical therapy, reassurance. You know, people from McGill require, a lot of them are pilots, and you got to have a high index of suspicion and make sure everything's okay for sure, because they're flying, you know, $15 million planes around over your house maybe. So, Pooh, what do you want to do next?
CCTA, that will give us answers whether it's the coronary, like it's a good sensitivity. So if we see CAD, we know if it's CAD. If we see something else that's abnormal.
So back to this is a song that I will keep singing, And so you're going to hear about this quite a bit because we're trying to introduce CT and MRI to HCA West Florida. So as you know, non-invasive cardiologists have been going around riding these little two-wheeled vehicles for a while, and they look pretty unstable to me. I don't know how that thing's standing up, but they got Echo and Nuke, and we're supporting that you should be driving this little red Ferrari with Echo, Nuke, CT, and MRI. And so, as you know, Echo slowly evolved since 1972 or so into a very, very good technology. I dragged an Echo machine from Indianapolis, from Dr. Feigenbaum's place, down to Tampa in 1972, and the people at Tampa General said, put it in the basement. We'll give you a room in the basement. This is not going to catch on. And Bill Strauss helped me start nuclear cardiology at Tampa General, and with the planar image that's very similar to that planar scanner up there. And that's evolved, I feel, into SPECT scanning, which is a fail, and then PET scanning, which is outstanding but very expensive. And then all during this time, CT and CMR has been gradually reaching maturity, but virtually ignored by cardiology except university hospitals and publications. And so all of a sudden now we've got two mature imaging techniques that really aren't being used in any of our hospitals. And so the question is, how do we bring this to full performance in a short period of time as mandated by the COCATS-4, or Committee for Cardiovascular Training for Cardiac Fellows. And so that takes us to the traditional cardiology algorithm, which I maintain is a false start, because we sell the six-pack, which is history, physical, EKG, echo, SPECT, and cath. And the gatekeeper is the SPECT scanner, which we can change those numbers now. It was $1,367. Each year it gets lower. Now it's like $500 or $600. And Blue Cross Blue Shield of Michigan had a 40% false positive. In the state of Michigan, that's like 47 hospitals. And someplace else in Ottawa, Canada, is an 88% false positive. And Blue Cross Blue Shield of Michigan was a 65% false negative. That's really pretty close to a coin toss. And so those patients go on to have cardiac cath. That's why we have 60% negative cardiac cath. And so the new model that we're proposing, which nobody can get to because they don't do CT and MRI, is a low-cost CT, less than $300 at Memorial Hospital. MRI about $500. And MRI is no radiation, CT is low radiation, and SPECT scan is high radiation. So, and of course the sensitivity and specificity is much higher on CT as well as MRI than the current stuff that we're using, and these are numbers from university hospitals, which where they haven't dumbed down the technology. And so let's look at the CCTA, which you ordered, Pooh, because you finally got on the program here, and you see that's our drift. So we'll take a look at that. Hang on. Unfortunately, there is a name on here. Certainly everyone here has signed HIPAA agreements, and we're HCA Florida, West Florida, so we're all HIPAA compliant. So please ignore if we did not delete names. And so we're looking through, this is our anterior and the sternum, and then we have posterior. And we're looking through this image at the pulmonary artery, which is in the center on the right, our right, not the anatomical right. And you can see the aorta on your left, and then towards the bottom is the descending aorta. And we're seeing some pulmonary veins come in. We should be seeing left atrium coming in soon. There's the origin of the left coronary. It's a normal anatomical origin. There's the origin of the right coronary. It's a little more superior than it usually is. It's at 12 o'clock. On this image, where usually it's at about 11 o'clock, this one's usually about 5 o'clock, the left. Let's see if it's 5. Yeah, it looks like about 5 o'clock, 4:30, 5 o'clock. And so we come back through here, and we're looking at the coronaries, and they're looking pretty good. We did inspect the coronaries thoroughly, and they were entirely normal. And the only thing we have here of any interest, which is our topic of conversation today, is the displaced papillary muscle that is oriented towards the apex. And so this is an apical instead of a mid-left ventricle papillary muscle. Very unusual presentation. Usually a papillary muscle is where my little arrow is. It comes up here, and this is an apically displaced papillary muscle base that's very broad. We can also measure the septum, posterior wall, and of course you saw that that was sort of borderline LVH or mild LVH. Everything else is looking fine here. Looking at the left ventricle cavity, we're looking at the right ventricular cavity, looking at the right atrium. Left atrium's coming in view, mitral valve, and everything else looks pretty good. So we've got an apically displaced papillary muscle. Pooh, have you ever heard anything like that, an apically displaced papillary muscle?
Yeah, I mean, it's in the lower third of the insertions down, so sometimes it can like mimic hokum kind of physiology, especially the apical variant, with same clinical features too.
Okay, and then we usually have a radiology overread, which basically was unremarkable. So what do we do next? And we gave you a whole raft of things to choose from here. We have normal coronaries, by the way, so going to the cath lab would have made the diagnosis of normal coronaries, but we wouldn't have gotten any further in terms of getting a diagnostic workup, in terms of understanding what was wrong with this patient. So we went directly to a less than $300 test, got the information, saved a lot of money, and some of our fellows were quick to jump on this and recognize, hey, look at that papillary muscle. It's at the apex. This is one of those things that if you don't know it, you don't recognize it. So you only diagnose what you know. And so we've presented a case recently of non-compactional left ventricle, the so-called mola-mola syndrome, of these two isolated non-compactions that we saw in someone. And nobody knew what it was because nobody knew about non-compaction. So you got to read and understand the greater repertoire of pattern recognition you have, the closer you are to not being replaced by a computer. So any comments on anything else you want to do, Pooh?
MR is an option to see if there's any obstruction caused by that papillary muscle or where exactly that's inserting, more spatial resolution. Okay. Other than that, if he's asymptomatic, erectile tolerance is good. I don't think we need to do it. It's just MR.
Okay, CJ, welcome to the conference. We're glad to have you here. CJ is Bayonet Point. CJ and I used to work together. She's in the cath lab there. Of course, we did some CMR. So let's look at our CMR. Hang on as we transition there. So here's a CMR that you can recognize that is not a CT scan. It's a black blood scan. CT scan, you'll have a bright spine. There's no bright spine there. There's no bright sternum. Actually, it looks like the brightest thing is some muscle and fat and stuff. And so actually fat's the brightest. And so we're looking here at the origin of the right coronary. We're over here looking at the origin of the left coronary. We're looking at the myocardium. Here's this papillary muscle angled towards the apex. It depends on how you cut this slice, but it's displaced to the distal 1/3, we call the apical segment. Black blood images are very helpful in understanding anatomy. And so this is actually, there's no contrast, it's just black blood sequencing, and very useful for telling us more about the heart. And so we just confirm what we saw before, is this papillary muscle sort of blending in. Look how thick the left ventricle becomes as this papillary muscle blends into the inferior apical portion, and actually the half of the ventricle is encompassed by this papillary muscle structure. I can see how this would give abnormal EKG, abnormal repolarization. I don't know why it changes since 1992 to now, why there's a gradual change, but there is in the EKG. And so we've got that markedly ischemic looking pattern, ST segment elevation. We've got the T-wave inversion, and all of that is because of this big hunk of muscle here that's this papillary muscle. The other papillary muscle is not well visualized in this particular view, and I don't think we have, we may have another view to show you that. Let's go over here. Can I bring that over? Oh, okay. Oh, there we go. Yeah, here we go. We can see the ventricle, and you can see it squeeze. That's pretty good. So you see it squeezes normal. You can see that there's really no significant mitral regurg. I'm running it back and forth by hand. So that looks pretty good. And we'll come through here, and we'll show you what we can. Oh, there's the apex. And we're working our way up through the left ventricle, through the chamber, getting a couple papillary muscles there. There's one anyway. Looks like that's really the big one. There's the other one opposite it. And so, and then we're coming up above that. So MRI is great. I love these pictures. I don't know if you're used to seeing pictures like this. Oh, there's the LV. Oh, there we go. Papillary muscles. Here we go. We've got the insertion. We got two heads on this papillary muscle, and it's squeezing, and the whole thing just gets really thick during systole. And look, it's almost obliterating the apex. Isn't that amazing? It doesn't look like the thing we see where you see the spade abnormality during systole and apical hypertrophy, but you can see this is an apical hypertrophy, but it's not the hypertrophic myopathy of Asians involving mostly the apex. It's these papillary muscles that are inserting, and so that's really, really very, very interesting. Here's a papillary muscle over on the other side. You know, I can't tell much about its insertion. We never look over here at right ventricular papillary muscles. And so there's some more systole. And these images are just beautiful. You can see why I would be involved in doing this technology. This is the right ventricular outflow tract. There's the aorta, some left atrium over there. Here's pulmonary valve. You can see why this would be so much fun to get these images that look so nice. Here's a papillary muscle. Here's a papillary muscle. You can't tell much about where they are. And then we're back to a black blood study, which is what we started with. We've got all kinds of stuff. I mean, look at this. This is really neat. This is a way of putting a grid on the left ventricle, and it can tell you all about these grid components moving back and forth, and you can measure strain with this grid. It's a very sensitive measurement of strain. The grid was first developed at Johns Hopkins in Baltimore by Dr. Zahudi. I went to visit him to see his grid. It was pretty cool. It still looks pretty cool. And so we've got another grid here. Here's the other grid. And so we can actually put this into a computer program, which we're going to be doing from Myocardial Solutions, and it's called HARP, and we'll be able to show you the strain measurements from this grid. And there's another one called Sync that'll give you the strain measurements of one heartbeat, which is pretty cool. Here's these papillary muscles coming from the apex. There's some artifact on that particular picture. This picture is probably a contrast study, and we probably got contrast moving through here, which can't make it go fast enough to see it. And there goes contrast. Here we go. We've now taken the myocardium, and we've actually filled the myocardial arterioles, and arterioles have been filled with contrast. So the contrast was injected peripherally. It was gadolinium, and the gadolinium came into the right ventricle. There it is. Comes into the left ventricle, comes in the coronary arteries, and then fills the myocardium equally all the way around. A few little gray artifacts, subendocardially, this and that, but essentially normal. And so that's beautiful. Really pretty. So this is the imaging study we do with Lexiscan and with REST, and then compare them. And so I don't know if you've ever seen that before. Anybody seen one of these before other than my presentations? And so this is the easiest way. You can make every MRI test, every MRI scanner can be a stress test machine using chemical stress, and you can actually do this in 10 or 15 minutes if you want to. which is pretty cool. And then we're trying to null the left ventricle so that we can look for scar, and we'll be looking for that in just a minute. But I want to show you this part where we're actually doing, all this stuff is called phase. And this is actually the same principles, for example, as Doppler, where we can actually measure blood flow in the aorta and pulmonary artery. We can measure the blood flow, which is just amazing. And we can tell you what the aortic valve area is. We can tell you anything you want to know about shunt flow. And this is probably the first presentation you've ever seen of phase, which is very similar to Doppler and gives us extreme capability of telling you anything you want to know about a valve or a shunt or a cardiac output for that matter. So very versatile technology. And now we've taken the heart and we've nulled it, which means everything is going to be black except gadolinium. And if gadolinium got caught in the interstitium because there was edema or scar tissue or something, we should see a bright white spot in the heart muscle itself, and we're not seeing anything that's a bright white spot. There would be just a big bright spot in there somewhere, depending upon what we're looking for. If you're looking for amyloid, sarcoid, if you're looking for myocardial infarction, that's what everybody talks about, and that's the gold standard for myocardial infarction. So despite all the stuff you saw on that EKG, there is no ischemia and no myocardial infarction demonstrated by any of these very sophisticated tools. Here's this papillary muscle insertion. There's the one we've been looking at. Here's the other one we haven't been looking at. And it also is apically driven. Doesn't seem like the alignment has done anything in terms of disrupting mitral valve apparatus, which is very sensitive. And there's no white spots, bright white spots in here of gadolinium enhancement. So we're happy about that. No scar tissue, no infarct, no ischemia. T2W tells us about edema, no edema. And so we have gone through this looking for all the pathology, and this is like a one test tells all. And basically we haven't stumbled upon anything that we hadn't recognized previously, but we ruled out a whole bunch of stuff, including microvascular obstruction with microvascular disease that gives you funny looking EKGs but normal coronaries. And so we've done everything non-invasively. This is what we feel the four-wheel Ferrari can do for us, give us all the information non-invasively. So let's go back to our slides again. Is there anything else you want to do on this patient, Malika? How about you, Pooh? Anything you want to do?
Not really, just reassure him. At this point, it's not gotten to the point where it's causing obstruction or anything to do beta blockers or something.
Yeah, so I actually, we don't see a lot of cases of the apical displacement of the papillary muscle. I worry about everything. That's my job. I especially worry about young people who are in the service. And so basically I was concerned that, you know, maybe there's a channelopathy, maybe there's something else. You've all heard of Brugada syndrome with ST segment elevation, right bundle. Maybe there's something else going on here that I'm missing. And so basically I did a Holter monitor. There's some PACs and PVCs. I'm always worried about funny looking EKGs leading to sudden cardiac death. And so by a spontaneous mutation rather than a familial genetic acquisition from birth. And so I've become very sensitive to that, so I send him to a cardiac electrophysiologist because of channelopathies. I think there are guidelines for channelopathy genetic workup by Canada. I know I saw those a couple years ago. There may be some U.S. guidelines by the Rhythm Society, and so basically I worry about that. I had him see an EP doctor. They performed genetic testing, and it was negative. So you don't hear a lot about genetic testing. We're going to tell you more about genetic testing. As a matter of fact, the patient we presented the other day with the non-compaction is going to get genetic testing. We're also going to test the family. And so we're not talking about DNA much, but we should be talking about DNA a lot more. And so hopefully every conference will say something about DNA RNA or protein. We have talked about protein markers, and we've talked about protein expressions. And one of the tests, which was the pulse test, there's another test called the Chorus CAD for coronary artery disease. That's 23 messenger RNAs. And so we're very involved in DNA, RNA testing, as well as protein testing. And so we want to tell you more. So the differential diagnosis of this is apical hypertrophic cardiomyopathy. So we need to know that he doesn't have that. So that means we need to know about another disease called apical hypertrophic cardiomyopathy. So let's take a look at one of our patients who had that. Okay. So it's more frequently found in Asians than Caucasians, but we see quite a few, and I've got several cases here. And so it's a expression of hypertrophic cardiomyopathy. Here's an EKG for you, Malika. What do you think about this one, and compare this one to the other one? And then if anybody was present on the patient that we presented with hypertrophic cardiomyopathy, you can think about that one too. So here we go. Take a look at this.
Let's see. So the rate is 100 beats, about 100 beats per minute. He does have a P wave in front of every current.
No, it's not really 100 beats. You count these little boxes. If you got 4 of these little boxes, it's 75. If you got 5 boxes, it's 50. To be 60. To be 100 beats would be 3 boxes.
Sorry, that's right. 75, not 100. Yeah. So he does have a P wave in front of every QRS complex. This is normal axes. I don't see a lot of Q waves anywhere. I see a lot of T wave inversions in lead 1, lead 2, AVL, V1, V2, V3, V4, V5, V6, basically throughout.
So you'd say ischemia, right? Ischemic T wave changes. And so there is when you mention Q waves, there is an absence of Q waves, and there's actually the absence of a normal Q wave. The normal Q wave is where, Malika?
So it should be right here.
So we always see Q waves in 1 and L and V5 and V6. And those Q waves are the depolarization of the septum from left to right. So basically, when you're looking at it directly, it's an R wave. When you're looking at it from behind, which would be from V5 and V6, it would be going the opposite direction from left to right. Septal depolarization would give you a tiny little Q right here, and it's not there, and it's not there, and it's not there. So that's an abnormality when you don't see the Q waves. So we're always looking for Q waves. What about absent Q waves? Absent Q waves should tell us something is different about this. So there's an absent Q wave. And so what are we going to do next on this one? What would you like to do, Malika? I know what Pooh's going to do.
For this patient, I would probably go ahead and get a stress test.
Let's see. So this patient is also asymptomatic. Now the last one asymptomatic, you were ready to go to the cath lab. Now this one you want a stress test. Can you explain?
It seems, just looking at the EKG, he has, it seems like he might have ischemia. So, the next step would be to do a stress test and see if there's any abnormality.
Okay, so let's see what happened. The patient was sent from the clinic with that EKG, no previous EKG for comparison, no symptoms, and the patient was sent from the clinic to the emergency room at a hospital. Okay, as a matter of fact, Brandon. So our hospital, patient shows up, and so what's going to happen when you show up in the emergency room? You're going to get some kind of traditional cardiology algorithm care, usually a 6-pack. And so this patient has a chance of getting some of these tests. Asymptomatic, they jump all over this case. The case is seen by an interventional cardiologist. What do interventional cardiologists like to do? Well, if you got a hammer, everything looks like a nail, but I feel like you should have different hammers. You should have a ball peen hammer. You should have a claw hammer. How about a rubber mallet? How about a tack hammer? How about having a bag full of hammers so that you can figure out which hammer do you need on this patient? So Cardiac catheterization was the choice that was made by the interventional cardiologist who basically is looking for something to fix. So hang on, our cardiac cath. And so we would like comments from Pooh, our cardiac fellow, since we can't get Melody. Melody, if you happen to be available, just let us know, because we'd like to involve you in this case too. But go ahead, Pooh, tell us what you think about the cardiac cath. We'll give you some images to look at.
So this is RAO projection. Circ looks pretty good. I don't see disease. OM, large OM, that looks okay. LED looks okay too. I mean, no disease that I see so far in ariocardial. And let's see.
I'm going to roll you through the cath pretty fast here. And you can comment as we see images. This is like a selective injection, mostly of the circumflex.
This looks fine. Circ looks okay too. And nothing sticking out so far, so no CAD.
Getting radiation for nothing on the previous one, but this one, here we go. What do you see? Anything popping up at you?
RCA looks good too.
Yeah, looking pretty good.
LV gram, let's look at that if we have it.
We're going to like this next injection. We're going to give you the left ventriculogram now. You ready for that?
Mm-hmm.
You're going to like this. This is a pretty one.
Wow. Yeah, systole, it's obliterating. It's spade-like.
Isn't that beautiful? That's the spade sign. Malika, that's the spade sign. And this looks like it's pretty appropriate for Valentine's Day coming up, because we could say it's like a heart sign if we can stop it at the right spot there. Hang on here. We'll see if that's going to be a heart for us. Well, look at that. Surprise. We've got, it looks like more like a conch than anything, but or a whelk, but it could be a heart. And so the heart sign, the spade sign, so especially during systole, let's look at the spade sign. And so that is usually seen with apical hypertrophy, but it can be seen sort of when you have a prominent papillary muscle or prominent papillary muscles in the apex. So it's very difficult to discriminate where we have displaced papillary muscles or whether we have a patient with apical tunnel left ventricle or apical hypertrophy of the left ventricle. But it's this is a beautiful image. This should stop you in your tracks. If you've been trained by me, it should stop you in your tracks and you say, oh, look, there it is. And so let's see what happened. Are you ready? Pooh, what are we doing now?
Is he trying to wire through it? Let's play it, please.
Whoa, Pooh, what happened to this beautiful artery we had?
Dissection.
So if you have a hammer, everything looks like a nail, and so that normal coronary now has been totally dissected with this wire in an attempt to put a stent in where we can't find a lesion, where the diagnosis of the spade-looking left ventricle during systole, telling you about apical hypertrophy or displaced papillary muscle, was missed by the interventionalist who's got his hammer out and he's starting to nail away. And so here comes the balloon and here come the stents. Pretty ugly looking when we inject that. Pretty ugly looking massive dissection of the right coronary. So beginning the process of angioplasty and then stenting, asymptomatic patient with an abnormal EKG. There's a stent now. We got a stent up there. Let's see if we can get some more stents in there. Nice stent in that pretty dissection. And here's our stent. There's our stent there. Oh, there's a stent above it. There we go. We got two. Looks like we have two stents. At least two stents in there now. So that's a good thing. You need a little metal in your chest once in a while.
I'm sorry, where is the other stent?
Maybe it's just one. Maybe it's just one. I was thinking there was another, but it looks like just one big stent. Run it backwards. Oh, wait a minute. Let's run it backwards. And we'll see if we can tell. Yeah, it looks like just one stent as we run that backwards. Tom, I have to call you back. I'm in a conference. So let's move on to non-traditional guided, image-guided, advanced cardiac image-guided cardiology. Hang on. So the patient who was previously asymptomatic started to now have symptoms. So she's got exertional retrosternal chest pain and typical angina. Goes back to her clinic at military Brandon, and basically is sent to me for evaluation now of new onset angina. Let's skip the echo. We're getting tight on time. Move on to more definitive understanding. So clinical findings of apical hypertrophic cardiomyopathy. Some people have dyspneic exertion, atypical chest pain, typical angina presyncope, giant T-wave inversions. Guess what? Giant T-wave inversions of the anterior lateral EKG. And these are some of the measurements of hypertrophy that we're looking for. And this spade-shaped configuration, the LV cavity at in diastole on not necessarily ventriculography, but ventricular imaging would be better to say that. And normal levels of the thickness at the base of the heart on CMR. So CMR is really our best image for this. Let's take a look. Well, here we are on MRI. So here's our black blood study. Wow. Ooh, what do you think about the apex of this left ventricle?
It's huge. It's more than 50 millimeters for sure.
Man, let's measure this sucker. Whoa, 27. And you can see how it narrows down towards the base. And it gets to be pretty close to normal as we get to the base there. Meets the criteria. And here's our left ventricle. There's our papillary muscles again. There's the apex, which is muscle-bound. Tiny little hole representing the cavity in the apex. And then heart thinning out as we go more towards the base. This picture looks pretty much like what you saw in the left ventriculogram. This is actually diastole, and we got the spade sign with the apex just sitting there, and there's no cavity to mount anything, and then the base having a nice cavity, giving us the spade or heart sign. These are kind of scrambled images. So it's pretty much, that tells us what we were looking for. Let's go back to our slides. And so now we have two things we're looking at. We're looking at apical diagnosis of apical hypertrophy, and we're trying to distinguish that between apical displaced papillary muscles. And one science patient sort of came in, one patient as far as our cardiac science came in, and came the cardiac imaging route, and wound up getting some very, very nice pictures, getting a genetic workup, and having displaced papillary muscle. The other patient came in the traditional route, both asymptomatic, both dramatic ST and T wave changes. The first one more dramatic than the second one. First one didn't get a cardiac cath. Second one comes in presenting asymptomatic, and has less severe findings on the EKG, gets a cardiac cath, gets a dissected right, and gets stents in the right, and doesn't get the MRI and the CT workup until later when she develops now classical angina because of the dissection of the right. So it's very interesting to see the distinguishing these two. And here's a papillary muscle that's in the apex, and here's a bunch of cords coming across and stuff. Here's another papillary muscle that's in the apex, and this is what it looks like with the apical findings. Here's somebody also who has basically not the resting hypertrophy of the left ventricle, but the apical insertion of the papillary muscle. Apical insertion of the papillary muscle. Some ventricular arrhythmia. This patient had previous bypass surgery, and hopefully not normal coronaries, and the apical insertion of the papillary muscle. And basically, this is not apical hypertrophy. This is not the Spade sign. The Spade sign is frequently seen at rest during diastole as well. This really has a nice diastole and a nice area of cavity at the apex. So distinguish the two: apical hypertrophy versus abnormal displacement of the papillary muscle. Treatment of apical hypertrophy, treatment of abnormal displacement of the papillary muscle, and angioplasty and stenting really isn't a solution to apical hypertrophy unless you infarct the LAD distally. And that's one of the sequelae is that happens. These are some of our references. Do we have any questions from anybody? Okay, well, thank you very much. We're glad you attended. We do have the conference tomorrow on our cardio-oncology conference. Starts at 9 o'clock if anybody's interested in attending that. That is an international conference involving U.S., Poland, London, and Tel Aviv, and other quarters of the world, frequently India. And if anybody has any I would appreciate comments about our presentations, as well as if you want an invitation to tomorrow's conference. It's eeharrison253@hotmail.com is the email address. Thank you so much. It's nice having our medical resident from Bayonet Point, Malika. We're glad you could come today, and hopefully we get Melody up so she can talk next time. And Dr. Pooh, we appreciate your coming as well. Thank you very much, all the Care Assure people and everybody who's involved in our programs.
All right. Thank you so much, Dr. Harris.
Thank you, Dr. Harris.
Bye-bye.
Bye.
Hi, Teresa, Shirley, Sandra, Shannon, Mindy, Michael, Mary, Janet, CJ, Christina, Kelly, and Janet, and Mary.